Yeah, I've been thinking about this for most of the night. And the reason I've been thinking about it for most of the night is because I forgot that I was doing this morning. And, and the reason I forgot doing it this morning is because it was put in my diary. I agreed to do it so long ago. And because I tend to live in the moment these days, it just never occurred to me to look at my diary on what is my only clinical day of the week. And I'm rather glad that that happened, to be honest, because it made me really consider research, which is my background, and what it means and where it's going. And I work for an organisation called Health Education England, and we're the workforce arm of the NHS. So in 2000 and whenever, 12, during the first of the coalition government's Health and Social Care Act, the Lansley reform split the NHS up into 6 arm's-length bodies. And the biggest of those is NHS England. And what NHS England do is they pay for stuff. So they pay for operations, they pay for technology, and they pay clinical commissioning group, and they pay for GPs, etc. The second biggest of those arm's-length bodies is Health Education England. And Health Education England are the workforce arm of the NHS. And our job really, I guess, is to make sure that the workforce of the NHS is fit for purpose for doing what it's meant to do. And I'm going to come back to some statistics about that in a minute. So we spend, as an organisation, $5 billion a year on the future and current workforce to try and keep a constant supply, but also to make sure that the people who are in work have some sense of lifelong learning. I guess I've come to talk about research. My background is that I'm a surgeon, as I've pointed out, and but I'm a clinical academic surgeon, and I've had a very eclectic career, really. I trained as a surgeon, I graduated in Manchester, trained as a surgeon predominantly in the West Midlands in India, and then I came back up here in 1997 as a non-clinical lecturer to do 12 months of research on a research fellowship called the Tom Jones Fellowship. No idea why, but nevertheless it was. And then became a clinical lecturer, senior lecturer in 2000, honorary consultant at the University Hospital South Manchester. Did a whole variety of educational roles, ran Manchester Medical School for a while, and then was jumped to the dark side to become a civil servant about 4 years ago with HEE. And I suppose one of the reasons why I've enjoyed my relatively sleepless night is thinking about what research is all about. And this thing here called the quadruple aim of care. And it was in the British Medical Journal about a year ago. And actually, the aim of research is very difficult to think about it because the Brian Coxes of this world are very often... better be careful because he might be next door, mightn't he? But the Brian Coxes of this world are very often criticised for doing research that doesn't have impact in terms of the way in which we live, which is a nonsense, but nevertheless they are. Whereas healthcare research, I guess, has 4 key areas where it should impact. And I guess these are it. It's improving the health of populations, improving the individual experience of care, reducing the per capita cost of care, and I will refer to that on several occasions during the course of the next half an hour, and improving the experience of providing care, and perhaps increasing joy and meaning in the workplace. And we need a lot of that at the moment, and so I thought I'd add that little bit in, even though it's not about the immediate quote, it's actually elsewhere in the text. Now, I'm going to argue in the next 20 minutes or so that there's never been a better time to get engaged in research. And I'm going to try and make an argument that says that that's the case. Now, as an educationalist, I know that there are only two truisms in education. The first is that everybody's an expert. And the second is that everybody graduated the year that education hit a pinnacle. And I know that because everybody tells me. Because everybody tells me it's not as good as it used to be. It's At the moment, the health service per se is going through a bit of an Eeyore patch, really, where everybody's wandering around thinking the end is nigh, etc. But I would argue, actually, we might be on the cusp of something really great. And I'm going to talk about all of these things very briefly as to why I think now is the best time there's ever been to get engaged in healthcare research. The first thing is we've got a new population, one that we've never seen on the earth before. We have 2.8 million people with diabetes. We've got an ageing population in the UK with 1 in 3 people who have been born in the last 10 years likely to become centenarian, to reach 100 years. Male obesity is a massive problem for us, up 10% in the last 9 years in the 2 to 10 age group. And the thing is about elderly and the fact that we're so good at treating stuff is it's a bit like those things at the fairgrounds where smack the rat or whatever they're called, where you hit one rat and another 2 pop up on the same side. So you give people non-steroidal anti-inflammatories for their hip pain and they bleed out because they perforate the gastric ulcer. And so care is becoming more and more and more complex, and therefore there's more and more and more for us to think about. The second thing is that despite the press, the National Health Service is truly phenomenal. And I think it's easy when we're heading through austere times as we are at the moment to forget that. NHS England spent £113.3 billion on health for the 60 million inhabitants, and there are 1.3 million direct employees of the NHS currently. By far, far and away, the largest healthcare organisation that has ever existed on the planet. We've got 209 clinical commissioning groups, 154 acute trusts. This is England alone, 56 mental health trusts, 7,875 GP practices. The emergency departments see 22.923 million cases a year. The NHS hospitals per se, or if you look at the NHS as a whole, there are 250 million NHS patient contacts a year. It's just utterly vast, and it's increasing all the time. There are well over 100 different individual professions within the health service, both clinically and non-clinically. Hugely complex thing, absolutely mounds of laboratory stuff to be investigated. The second reason why I think that that the NHS is entering a really special time at the moment is for the 70th time in 70 years we're undergoing a major reorganisation. And this one's actually quite unusual because the prevailing theory is that local people know more about what they require than the NHS as a whole. So the NHS has always been seen as a large organisation which has one way of doing stuff. And that is rapidly changing. And underneath the 5-year forward view, which I'm sure you've all heard about, which is the NHS's current work plan between the 6 arm's length bodies, we split the country up into 42 sustainability and transformation plans. And each of those sustainability and transformation plans is being empowered to do their own thing under the NHS banner. So the way in which we've delivered care traditionally over the last 70 years is changing as we speak. Real opportunity. This is just some information about STPs, which I'm sure you've heard about. They will be a place-based, multi-year plans built around the needs of local populations, absolutely key. And the attempt is to transform the way in which we deliver care to 2021. My own organisation has changed its strategic direction completely. And there will be lots of you in the audience who will be aware of what happened at the Comprehensive Spending Review in October last year. And prior to that, our organisation was responsible for commissioning the future workforce of the NHS. Now, the responsibility for commissioning the future workforce of the NHS is the individual themselves through the student loan company. And that has made us rethink about what our role may be. And we've define that really in these 3 key areas. Again, all completely new. What we're being tasked to do, from a statutory perspective in fact, is to keep an eye on the workforce and to make sure it's heading in the right direction in an unregulated market, completely new. We're shifting the focus, I'm going to come back to this in a big way in a minute, but we're shifting the focus of the metrics and what we look at to make sure that we're educating and training in the right way. And we are responsible as an organisation for turning people into a different direction and making them work in a different way. Okay, so one of the things which we're concentrating on very much, or the several things we're concentrating on very much at the moment, you can see up here, we've always been responsible for supply. We've currently got some 280,000 undergraduate people coming through the system at the moment in various different professions. But we're now thinking about how we upskill people who are currently in practice, how we spend our continuing professional development and workforce development monies. We're developing a whole series of new roles, never been developed before. Physicians associates, I'm sure you're familiar with. Nurse associates, there's the Royal College of Emergency Medicine have created a new multi-professional advanced practice role as well. And we're looking at new ways of working within those roles, all of which we know nothing about in terms of impact and how it might affect the system. So our key issues are expressed in this. This is our HEE overall plan. It's called the HEE STAR. And what we do is we concentrate on the supply of workforce currently, new roles, sorry, the slide's not terribly good, new roles, the development of leadership within this new NHS, what does that look like, new ways of working, and altering or turning people's direction into developing lifelong learning trajectories which are currently not available. We know that the healthcare population will require over the course of the next 20 to 30 years. Big challenges. We've introduced all of these policies. We've no real idea what the impact is likely to be. Masses and masses and masses of data will be generated on the basis of this, masses and masses of opportunity for trying to find out what this all means and how it's going to affect us. Okay, so I'm going to talk a little bit about education at the moment and give you some startling facts. I know that the audience is predominantly non-medical. I'm going to tell you something which you already know, is that the world of education is very, very unfairly biased towards doctors within the healthcare system. I'll give you an idea of how biased. So every current undergraduate medical student, when they are placed within a hospital environment, carries with them £34,800 per year, which is given to that trust. Okay, so over the 3-year period that medical student is in that trust, the trust receives 100,000. Got 100 students, you can see it's a lot of money. Nurses, £3,800 a year. Okay, we know that that's wrong. But what's happened, because that money has been invested over 500 years, in fact, but certainly over the last 70 years, been focused towards doctors, is that doctors have developed a whole range of very clever ways of monitoring progress, assessing people in education, developing portfolios, developing supervision, a whole host of stuff which has not been open to the rest of the system. And we've been tasked with changing that and changing it in a big way. And so we're altering the flows of money to our STP partners. But perhaps more importantly, and this is key and more scholarly, is we're moving away from focusing on the quality of teaching that a particular profession might get and starting to put all of our focus into clinical learning environments. Digress slightly, if going back to basic educational principles, we know that there are fundamentally 3 columns or 3 pillars of learning. The first is what we learn, or what we scholarly call curriculum. The second is role modelling, because we know that has a massive impact and it's the basis of apprenticeship. And the third is the environment in which we work. Almost for 500 years, maybe even longer, we've focused on the first. So if anything goes wrong, and any of you who work in a higher education institution will tell you that's the case, the students get a bit miserable, the MSS scores drop down. What's the first thing you do? You redesign the curriculum. Makes not a jot of difference. Okay. Study done in the United States by a bit of a geek called Clark, who's actually Canadian, looked at the National Board of Medical Examiners licensing exam, which is something that anybody who practices in the US has to sit before they can practice as a medic. And he looked at 186,000 consecutive candidates' performance, told you he was a geek, okay? And what he showed quite categorically is less than 3% of the variance in terms of performance was due to where that person studied. And they could come from all over the world. So it didn't matter which curriculum they studied. They were either good or they weren't. And what made them good, when he looked at that, was the role modelling and their clinical learning environments, how good their clinical learning environments were, how good the quality of care was in the place that they learned. Okay? And we as an organisation are now shifting away from focusing on professions and working with provider organisations to look at clinical learning environments and making them better. Great in theory, the underpinning research is missing. We need it. It's a big issue for us. If you think about clinical learning environments a little tiny bit further, and we're all as health professionals exposed to that, what are they for? Well, for the students, it's fairly obvious. They're about learning high quality and safe practice, application and development of skills, socialise with other students, patients, cultures, values, behaviours, etc., and access to a breadth of roles, in other words, giving you inspiration and drive and ambition for the future. But actually, they have a much bigger effect potentially on the people that you work with. And in a very, very positive learning culture, it improves the productivity of the existing workforce, it improves satisfaction in the existing workforce, it actually improves the physical health and absenteeism rates of the current workforce if you've got a good learning culture with plenty of learners within it. In addition to that, our students, our learners, have an impact on the whole population. You only need to speak to the elderly lady in bed number 4 in her mid-80s who lives alone normally, and you can bet your bottom dollar that 9 times out of 10 it's the nursing student or the physiotherapy student that she refers to when she says, "What's made your experience good?" Okay, really massive impact. We've never measured that. We've never looked at it. We've never thought about the psychology or the behaviour that actually makes that happen. Massive opportunity. Okay, another opportunity, technology. I mean, what is going on there? Okay, so when I was learning IT, 20 years ago, we walked into ITU. We used to have this thing called 6-pump syndrome. And I mean, dark humour, and I apologise, but it does illustrate the fact. And we fairly certain that if somebody had 6 machines attached to the side of them, then they weren't going to leave ITU. Nowadays, you can walk into an ITU and it looks like something out of a science fiction movie. Okay, technology is massively, and it still shows no sign at all of slowing down. We don't really understand the long-term impact of these. And what's interesting specifically about technology is that there's lots of nerdy stuff that goes on with the inventors in the large areas of scholarship like the University of Manchester, but actually most of its usage occurs within district general hospitals or within primary care where there's no research activity at all. Massive, massive opportunity. This is just to illustrate how technology has changed in its rapidity. Okay, none of these things existed in 2005, none whatsoever. Okay. A tweet was still a sound, okay, in 2005. Ain't anymore. The cloud was still in the sky, okay. All of this has changed in the last decade. Far, far quicker than we've been able to do solid, either quantitative or qualitative research and apply decent research methodology. All of this is available, we need to understand. Some of this is being reflected in terms of funding as well. And I think this is key because and I think I'll probably keep coming back to this in the next couple of slides. So the research community, whilst it's very often given an ivory tower look or an ivory tower label, are very often the quickest to respond to change because they recognise that their bread is buttered on doing something new. And certainly if you look at the research councils and what's happened with the national research councils in the UK, the whole emphasis of research and what they're investing in at the moment has changed dramatically over the last 10 years. So we're looking at stuff like big data, we're looking at stuff like measuring skills, impact in the medium to long term. When the NIHR was set up, the first rule was that they weren't going to fund anything that wasn't going to show a patient impact within 5 years, which meant that all education and training was out. They've taken that cap off completely and in fact have come the whole other way round now and are desperate to invest in education and training, policy, research, really very, very important. All changed over the last decade. We're tending more and more to look at impact-based research and policy-based research. These are some of the key priorities for our national research councils at the moment, and if you look at them, they're very vague. Primary care impact, diagnostics, children and young people, population, public health and prevention, education and training reform stuff. There's a real need to understand why and what will have a positive behavioural change and a positive impact on patient care that we really at the moment really poorly understand. So I put this slide up because I think it's really important, and it goes back, first of all, it goes back to the fact that the NHS is just simply fantastic. If you look at Greece spends 11.1% of its GDP on health. The United States spends somewhere between 19.5 and 21.8, depending on where you are, percent of its GDP on health. We spend 8% and still have the best health outcomes in the world. Okay, and we all know we're skint. We all know that our current regime has, for the first time ever in real terms, has reduced the money that has gone into the NHS year on year. But one of the key things about necessity and change and the fact that you haven't got the resources is that you need to innovate. And actually, the motivation and the opportunity to innovate, I would argue, now is greater than at any time in the NHS's history. Fundamentally, because we've never been poorer. So it isn't all necessarily bad that we're going through an austere period. Now, I would not say that to the ministers, frequently haven't said it to the ministers, but it isn't necessarily all, and for a research community, it drives innovation. You can see that if you look at outputs, high-end outputs from communities that are suffering a downturn in their resource, you'll see that their output does increase. It's not sustainable forever. At some stage, somebody's going to have to turn the tap back on. But actually, it's a really good environment at the moment to be innovative. So I've just put this in here. So healthcare in the UK is underpinned by world-class lifelong education and training that is enhanced through innovation and research and the use of evidence-based existing and emerging technologies and techniques. For me, this sums up why the NHS is so good. It's got all of those things. And because of the intuition of a post-war Britain and several politicians at the time to introduce this, it's had a massive impact, not just on UK health, but also as an exemplar for the rest of the world. But it's underpinned by innovation and research, and we need it now more than any other time. So these are just some of the things. So if you read, I'm not sure how many of you read healthcare policies, but all of the sustainability and transformation plans, for instance, would be a good place to start. So they all say what they want to do in their local area, and then they all come to a workforce section, and then they all talk about this mythical new workforce. And the words that they use are up there. So a workforce which takes more individual leadership, which is more aware of population health, which is more aware of managing risk. It's making do with poor resources. Equality and more understands equality and diversity, is more culturally competent, is more focused on patient safety. The reality is that this healthcare worker doesn't exist. Not only do they not exist, but we don't know how to make them. So there's a big opportunity for us understanding how to change our behaviours and attitudes into this new mythical healthcare beast that we need over the next 50 years. So this is just a bit more of a formal way of describing what I said on the previous slide. So what it says in the 5-year forward view is that the workforce will need to continue to help people to prevent ill health and manage their own care, have the skills, values and behaviours required to provide personalised care, have adaptable skills responsive to innovation and enable whole person care, have the skills, values and behaviours to provide high quality care and deliver the NHS constitution. Now, to my knowledge, none of us really do that at the moment, and not only that, we don't really know how to do it, certainly not for a population which is ageing, the population that we mentioned before. Interestingly, and this sort of proves the point of what I said in the previous slide, is despite the austerity of primary or the lack of resource in terms of delivering care, the money that's being pumped into research is increasing year on year. And it's coming from a whole series of unusual sources. So the BRIC countries, China, India, etc., who are cash rich and resource poor, are pumping huge quantities of money into research. Pharma and commercial companies, pharma, for instance, have a combined fund at the moment to understand behavioural change, which has been unspent because they don't know how to invest it because people are not doing research in the right area. Lots of charitable organisations are using research now as a front end to their expenditure as opposed to the delivery of care. And also our own research funding within the UK has been ring-fenced because we recognise that we need to research ourselves out of the situation that we're in at the moment. A really good time actually for commercially for applying for money as well. But you may have to think in a different source than the traditional MRC and NIHR. What I want to finish with really is just to mention that we're not alone in this. And I think this is relevant because of the next slide. So the WHO produced a document last year, actually 2014, that maintained that we want to create this thing called universal healthcare coverage, which is the notion that everybody has access to healthcare of a very baseline standard. And they estimated that we are deficient of about 12.9 million healthcare workers. Having said that, it's probably only scraping the surface, because at the beginning of this year, the Indian Skills Council, the new Indian Skills Council, produced a document that suggested they were 6 million doctors short of what they needed to deliver healthcare, and 60 million healthcare workers. So we're not alone in this. We've got a 29,000 deficit in nurse vacancies at the moment, and a very large number in doctor vacancies, a large number of AHP vacancies. But we're not alone in this. However, what we do have that nobody else has is the NHS. And one of the things that we're thinking about at the moment is what makes the NHS special. And we've mentioned the size, and we've mentioned its history, but actually there are two really key universal selling points for the NHS, and I've tried to sum them up here. The first is that we are the world's leading experts in developing healthcare systems at low cost. We've demonstrated we've done it for 70 years, and we've done it for 60 million people. Nobody else has done that. We're not doing anything about, or very, very little about, understanding how we can spread that and how we can use that to improve our own, not only our own healthcare system, but the healthcare systems of populations across the world. And the other thing that we do better than anybody else is train people and educate people and give them lifelong learning. So no matter how much we complain about our educational role at the moment, what we have, again, is a low-cost, very, very high-quality workforce to deliver care which is free at the point of contact. So there's a big opportunity there to transfer some of that and to find out and to understand the methodology of transferring that to other countries. So my own opinion, in summary, is that NHS is fantastic. Massive opportunity. There's keen investment because of austerity at the moment, and I'm absolutely certain there's no better time to be getting heavily into research and developing your own portfolio. Thank you. Yeah.